Yeah. Efficacy of 0.01% topical atropine in pediatric myopia. The time limit, the timer has to be started. Thank you.
Good morning, everyone. My study today is efficacy of 0.01% topical atropine in pediatric myopia as prospective study. The purpose of this study is to evaluate the efficacy of 0.01% atropine in pediatric population South India. It is a case series. Children between 5 to 16 years were enrolled in the first year and they were followed up for 2 years. So study duration of 3 years. It is conducted in Geetham Institute of Medical Sciences and Research. Written informed assent was taken. Actually, while explaining the assent, many of the kids' parents were not willing for the study. So only 8 people only we could enroll. And spherical equivalent of -1 diopter or more in either eye is included. Active myopia progression of at least spherical equivalent of -0.5 diopter over the last 12 months was included. An astigmatism of less than or equal to -1 diopter, distant vision corrected to 6/6 in both the eyes, and normal posterior segment were included. Exclusion criteria are allergy to atropine, history of any cardiac or respiratory diseases, ocular diseases like congenital abnormalities, amblyopia, astigmatism more than 1 diopter and high myopia, previous ocular surgeries, and lost for follow-up. Procedure, a complete ophthalmic examination was done. Every child was advised 0.01% low dose atropine to be instilled daily once in the night for both the eyes for a 2 years period and was reviewed every 6 months, and the parameters which were taken into consideration was spherical refractive equivalent, and the axial length and the pupil size. After 2 years, the 0.01% atropine installation was stopped and again reassessed for every 2 years. But now only the first 2 years period is finished. We have to still stop the drug and reassess during the washout period. And the plan is if the myopic progression recurs during this washout period, again we will start the 0.01% atropine eye drops. So the results are the age distribution was 2 years of 9 years age, 2 patients of 9 years age, 2 patients of 12 years age, 2 patients of 14 years, and 2 patients of 15 years. Gender distribution, 3 are males and 5 are females. And out of 16 eyes, 5 were myopic and other 11 were compound myopic astigmatism. And coming to the results, only one case showed increase in spherical equivalent refraction during this 2-year period. And in axial length, 2 cases showed increase in axial length progression. Whereas in the case 6, there was no increase in spherical refraction, but a 0.3 mm of increase in axial length progression was there. Pupil size, in 4 cases, definitely there was increase in the pupil size diameter. So discussion, this case series showed similar findings as ATOM study 2 and Indian atropine study, where it has demonstrated the effectiveness of 0.01% atropine eye drops in stabilizing the myopia progression. 7 out of 8 cases showed no change in spherical equivalent refraction, and only 1 case experienced an increase in spherical equivalent refraction. And axial length, 2 cases showed an increase in axial length, whereas other 6 did not show an increase in axial length. This shows the positive effect of atropine in stabilizing the axial length, as similar to the findings of ATOM study 1. Pupil diameter, 4 cases have experienced increase in pupil diameter. The effect of atropine on pupil dynamics is variable and it aligns with the observation with the other studies. Conclusion, the majority of cases exhibited no change in the spherical refraction equivalent and axial length for 2 years. It exhibits the potential benefit of 0.01% atropine in Indian eyes. Increase in pupil diameter is definitely a side effect of this low dose atropine, but patients did not experience any symptoms. Study limitations, it is a small sample size and an absence of control group, so impairs the generalizability of the findings. Larger control studies with extended follow-up periods are necessary. Thank you.
Are there any questions from the audience?
Is there any effect on the reading capacities of the children by using this atropine drops treatment? Is there any defect in ear vision happening?
Yes. Studies have showed the side effect of atropine as blurring in the near vision, photophobia, itchy eyes. But in my study, they didn't complain any blurring in the near vision with 0.01% low dose atropine. Sir.
How was the axial length assessed in your study, madam?
A scan, sir, and we have repeated it 3 times. And the reading was taken.
Was it done by different people?
Yes, sir. The
or
optometrist, it is a blind procedure. I didn't do,
Yes.
sir. The optometrists have done.
Okay. The same person repeats it for 3 times?
Yes, sir. In my institute, the MSc optometry one professor is there.
Yes.
He has only handled these cases.
Okay, okay.
Yes. Pardon, sir?
No,
Ultrasound
ultrasound,
scan.
ultrasound only. Was it normal A scan or A scan biometry or immersion A scan biometry?
In few cases, we have repeated with B scan immersion thing, sir.
Yes.
And we have concluded the same axial length.
And you didn't encounter any patients with side effects?
No, sir.
Yeah.
Fortunately, till now, no.
Yeah. Any questions from the audience?
Yeah, it is 0.3 mm. Maybe next third year, if we reassess, maybe there will be increase in spherical reflection in that case.
Thank you, madam.
Thank you so much.
Can we have the name R. Garala? Is he present?
The next presenting author, yes. Himani? Yes. There is a problem with his presentation.
ऑनलाइन नहीं है सर, अभी करवाना है।
Already given.
Good morning, one and all. I'm Dr. Harita. Today I'm going to speak on effect of cyclopentolate on ocular biometric parameters. There are no financial interest to disclose in this study. Coming to introduction, accurate measurement of axial length, anterior chamber depth, and corneal curvature are essential for calculating intraocular lens power according to different formulas. Assessing the anterior chamber depth is important to determine whether there is enough room for posterior chamber intraocular lens, as shallow anterior chamber depth or narrow angle can increase the risk of iris pigment chafing, and overestimation of anterior chamber depth can result in corneal endothelial cell damage. Cyclopentolate, it is a synthetic anti-muscarinic cycloplegic agent which is available in 0.5% and 1% solutions.
Hello.
And it is widely
1, 2, 3,
acceptable
check.
drug. It is a widely acceptable drug of first of choice for patients of all the ages, and it provides an excellent short-term cycloplegic effect. The main aim of this study is to assess changes in ocular biometric parameters before and after dilatation using cyclopentolate 1%. The objective of this study is to compare the effect of cyclopentolate 1% on the parameters anterior chamber depth, lens thickness, and axial length before and after dilatation. Coming to materials and methods, this is a prospective observational study done for a duration of 3 months. Using convenient sampling, I have taken 25 patients with cataract, and informed consent and institutional research committee approval was taken. Coming to inclusion criteria, I've included the patients of age group 45 to 75 years who are having a clear central cornea and cataract according to LOC3 grading and no other ocular or systemic diseases. Coming to exclusion criteria, I've excluded patients with previous refractive corneal surgeries or patients having any corneal ectasia or coexisting corneal pathology. Methodology, anterior segment evaluation was done using slit lamp and ocular biometric parameters, anterior chamber depth, lens thickness and axial length were measured using A scan by immersion technique in supine position, and the parameters were assessed pre-dilatation, and the patients were dilated using cyclopentolate 1%, 1 drop every 10 minutes for 3 applications, and the parameters were assessed 30 minutes post-dilatation after the 7 to 8 mm of dilatation. And the data was analyzed using mean and standard deviation. The parameters were compared using pair t-test before and after dilatation, and the data was analyzed using Microsoft Excel sheet. P-value less than 0.05 was considered statistically significant. Coming to results, the axial length has shown no significant difference in pre and post dilatation, but the lens thickness and anterior chamber depth has shown with p-value significant difference in post dilatation. So coming to discussion, the results of this study showed statistically significant difference in the lens thickness and anterior chamber depth post cycloplegia. Ocular accommodation increases the lens thickness and it moves the lens forward, while temporary paralysis of the ciliary muscle, it leads to an increase in the anterior chamber depth by reducing the crystalline lens curvature and backward displacements of its geometric center. So anterior chamber depth is an important factor in IOL power calculation. So imprecise measurement can lead to undesirable refractive errors after cataract surgery. Similar studies, Tao et al. Has showed significant changes in the anterior chamber depth and axial length post cycloplegia. Another study, Momenti et al. Has showed cycloplegia resulted in deeper anterior chamber depth and thinner lens thickness. Coming to limitations, I've taken a small sample size and I've used only single drug to assess the changes in the parameters. Coming to conclusion, cycloplegia can significantly affect the ocular biometric parameters. That is, it can result in deeper anterior chamber depth and thinner lens thickness. So changes in these ocular biometric parameters should be considered in calculating intraocular lens power calculation to prevent refractive errors after cataract surgery. These are my references. Thank you.
Any questions from the audience?
So in a routine cataract surgery, would you prefer to examine ACD with cyclopentolate or without cyclopentolate?
Usually we use tropicamide with phenylephrine combinations.
Before you do axial scan, A scan.
It's better if we don't, if we prefer to take it before dilatation.
Because the real life scenario is before dilatation. You can't keep the patient dilated.
So, but in most of the private setups, they do examine the patients after dilatation.
No, not necessarily,
They'll measure the axial length, so it's better.
Unless there are something, sometimes the A scan don't give a reading pre-dilation, or else you do pre-dilated only.
Nice. Thank you.
How did you actually exclude the corneal ectasias? Did you do any type of topography or any other instrument?
No, sir. Based on anterior segment only.
Okay, only clinical
And
examination
keratometry,
and keratometry findings.
Keratometry findings are taken.
Okay.
Thank you, sir.
Any questions from the audience? Please give the mic.
There was one study you had put AIOCMTC2 et al., right?
Yes.
So which showed a significant change in the axial length pre and post dilatation.
Yeah, that study has shown there is
So was there any
significant difference.
reasons for your changes in the
Yes,
angle, like the anterior chamber depth and all that? So what was the pathology like behind this change in axial length
Uh,
in that study? Steve, thank you.
Thank you.
Thank you. Okay.
Good morning, everyone. I'm Dr. K. Krishna Priya. Today I'm going to speak about correlation of AC by A ratio and stereo acuity in myopes. There is no financial interest to disclose. And coming to introduction, what is myopia? It is a type of refractive error in which parallel rays of light coming from infinity are focused in front of retina when accommodation is at rest. Prevalence of myopia is about 3.6 to 36.5% in Andhra Pradesh, and American Optometric Association has defined 3 grades of myopia, divided into low myopia with less than or equal to 3 diopters, moderate myopia 3 to 6 diopters, high myopia more than 6 diopters. AC by A ratio, it is the measurement of convergence induced by accommodation per diopter of accommodation. In other words, it's a relation between accommodative convergence expressed in prism diopters and accommodation expressed in lens diopters. This relation is linear and relatively stable throughout the life. Normal AC by A ratio is about 3 to 5 prism diopters for 1 diopteric of accommodation. It is measured by heterophoric method and gradient method. Stereo acuity is a measure of ability of the eye to detect horizontal minimal disparity beyond which no stereoscopic effect is produced. This limiting disparity characterizes person's stereoscopic acuity. Normal stereo acuity is about 40 to 60 seconds of R. Stereo acuity is excellent at fovea but decreases from center to periphery of the retina. It is assessed by using Titmus flight test, TNO dot test, Frisbee test, and Langhans test. And aim to study the correlation between AC by A ratio and the stereo acuity in myopes. Objectives: to study AC by A ratio in various degrees of myopia, to study stereo acuity in various degrees of myopia, to study correlation between AC by A ratio and uh, stereo acuity in various degrees of myopia. Coming to materials and methods, study type is prospective observational study, duration 3 months. I have taken sample size of 45 by convenient sampling. And inclusion criteria: myopic patients more than 5 years of age, and exclusion: amblyopia, keratoconus, congenital cataract, congenital glaucoma, and any other ocular pathologies. Methodology: obtained institutional research committee and ethics committee approval, taken written informed consent, and a total of 45 patients will be considered and divided into 3 groups: low, moderate, and high myopia. Children have undergone routine subjective refraction and ophthalmological examination and followed by AC by A ratio, by heterophoric method and gradient, and stereo acuity by Titmus flight test. Statistical analysis: Pearson correlation coefficient was used to correlate between AC by A ratio in each group, and ANOVA test is used to compare between 3 groups, and P is considered to be significant. And coming to results, AC by A ratio, on increasing myopia, there has been increase in AC by A ratio significance, and also significant difference between significant reduction in stereo acuity with increase in myopia, and there is a negative correlation present between AC by A ratio and stereo acuity that indicates increase in myopia increases AC by A ratio, which decreases stereo acuity. And coming to discussion, in this study there is a significant difference between AC by A ratio and stereo acuity with increasing myopia, and negative correlation between them on increasing myopia. And my GH et al. Study concluded that emetropia could have affected stereo acuity through reduced visual acuity and possibly other factors, which is similar to our study results where increase in myopia have reduced stereo acuity. And Vivekanand et al. Study shows that in a group with myopia, more than 3 diopters have a high AC by A ratio than in group with myopia less than 3 diopters, which is similar to our study. And in conclusion, with increase in myopia, there is an inverse relationship and negative correlation between AC by A ratio and stereo acuity were observed. These are my references. Thank you.
Which is the best method to assess a stereo acuity?
I have done Titmus flight test, sir.
Okay.
It is usually done even for adults. It is most easiest and to explain to the patients.
Yes.
And it will be easier to them, sir. So
Okay. Are there any monoocular cues in litmus fly test?
Yes, sir.
Yes.
In one box, there is darker one to mislead the
Yeah.
stereo acuity.
And then you did the statistics with the logarithmic value or the stereo acuity value you got?
Logarithmic, sir. Like there are we measure as it is in titmus flight test we have with seconds of arc, sir.
Yes.
So according to that, I have taken the value and have done the measurements, sir.
No, you measured the direct value of stereo acuity.
Yes, sir.
Not the logarithmic
No,
value.
sir.
That's not correct.
Okay.
Okay, you have to do the logarithmic value and then you have to do the statistics with the logarithmic value.
Okay, sir.
Because stereo acuity is it's not in an arithmetic progression. It is a logarithmic progression. Okay. So,
Thank
any
you, sir.
questions from the audience?
Yes, ma'am. Yes, ma'am. I have done, ma'am.
You have done cover.
Yes, ma'am.
So there are no exophorias at
For some people, there have exophorias and esophorias, ma'am. Like latent, ma'am. Not they have latent. There is no exotropias, ma'am. I have excluded exotropias and esotropias. Any on cover and uncover test, we have taken esophorias and esotropias, ma'am.
Well, that also affects the stereo acuity. Okay. Yes. Nice presentation. Thank you. Next speaker is a study of Barrett 2 versus SRKT formula to calculate IOL power using immersion ultrasound biometry by Dr. Radhika K.
Good morning, everyone. Myself, Dr. K. Radhika, today going to speak about a study of Barrett's 2 versus SRKT formula to calculate IOL power using immersion ultrasound biometry. There are no financial interest. Introduction, cataract surgery is considered as a refractive procedure, so estimating the intraocular lens power accurately is crucial for cataract surgery refractive outcome. One of the commonly used formula, the standard Ritzer and Kraft theoretical formula that was introduced in 1990s, formulated as a combination of both regression and theoretical approach, has been found to be accurate, particularly in eyes with axial length more than 27 mm. The Barrett universal formula, an updated version of BU formula, was introduced in 2010 by Graham D. Barrett and has shown promising results so far. Aim is to compare the predictive accuracy of refractive outcomes after cataract surgery using SRKT and BU2 formula. Objectives to assess the refractive outcome after cataract surgery using SRKT formula, to assess the refractive outcome after cataract surgery using BU2 formula, and to compare the refractive outcome after cataract surgery between SRKT and BU2 formula. It's a cross-sectional analytical study with sample size 60 patients, 30 patients in each group. Patients were randomized into 2 groups using random tables. Study duration is 10 months, done in a tertiary hospital. Inclusion criteria is patient above the age of 50 years, existence of age-related immature cataract based on LOX3 staging, and no history of previous surgery of anterior or posterior segment of eye. Patients with retinal or corneal pathology, traumatic cataract, congenital cataract, complicated cataract, glaucoma, squint, corneal degenerations, high corneal astigmatism were excluded. Patient demographic details have been recorded, and all patients have undergone a complete ocular examination, including best corrected visual acuity, IOP measurements, slit lamp examination, and fundoscopy. Biometry, IOL power calculation by A-scan ultrasound by immersion method, and ARK mission. All patients have undergone standard FECA emulsification procedure with 2.5 mm incision, and implantation of foldable IOL is done. All surgeries were performed by single surgeon. Only uneven
full surgeries have been included. BCVA is measured at post-operatively 6 weeks. Refractive error predictor versus obtained was tabulated. Comparison of outcomes in both groups were recorded. The collected data was entered and analyzed using Microsoft Excel 2019. Independent sample t-test was used to compare the means between two groups. Bland Altman plot was constructed to see the agreement between two formula of IOL power calculation. And the mean age of my study is 63.81. The predicted error does not have the mean significant difference, whereas obtained error between SRKT and BU2 formula has mean significant difference, p-value less than 0.01. Whereas in SRK2 group, there is mean significant difference between predicted error and obtained error. And in BU2 formula also, there is mean significant difference between predicted error and obtained error. In Bland Altman plot, we can see the 93% confident interval. Discussion in the present study, the Barrett universal formula provides a better predictability of IOL power calculation than the SRKT2 formula. In Demena et al., the study concluded that Barrett universal 2 formula outperforms both the SRKT formula and Hage's formula for highly myopic eyes. Whereas in Kutamarol et al., the Barrett universal 2 formula performed as the most accurate formula in the prediction of post-operative refraction over a wide range of axial lengths. The limitation of study is, although immersion ultrasound biometry was used in this study, optical biometry is often preferred for assessing ocular parameters in order to determine the IOL power using the BU2 formula. The conclusion of the study is the Barrett universal 2 formula provides a better predictability of IOL power calculation than the SRKT formula, clinically helpful for improving the refractive accuracy post-cataract surgery. These are my references. Thank you.
So, which is one common thing between Barrett 2 and SRKT?
In SRKT, we use theoretical and regression. Both are calculated in the this thing. We do not do it manually. It is done only in a biometer, or we will have a calculator.
So, the machine uses regression formulas and arrives at a particular value.
Yes,
in both.
both.
Okay. So, and that is the ability, and what is the inability that is common?
Inability is in Barrett's we want AC depth, which is better, can be done in optical biometry. But
Yes.
even immersion ultrasound biometry, you can have the AC depth. Because in nuclear dense cataracts, we cannot do the optical biometry cannot analyze the AC depth and axial depth.
So, in all the formulas for IOL calculation, which is the one factor which cannot be measured by the existing machines? The effective lens position, that cannot be assessed by any machine that is available right now. Yeah. Thank you. Nalma Siddiqui, she will be talking on microcornea with pathological myopia associated with posterior staphyloma and nystagmus.
Good afternoon, everyone. Today I'm going to present a case of microcornea associated with pathological myopia and posterior staphyloma with nystagmus. The patient has provided a written and informed consent, and there are no financial conflicts of interest to disclose. A middle-aged female patient presented to the eye clinic with complaints of gradual and progressive diminution of vision in both the eyes since childhood, associated with watering. It was not associated with any pain, swelling, or redness of the eyes. There was no history of trauma or drug intake, no history of any ocular surgery, no significant past or family history, and no case of any systemic illness. On ocular examination, visual acuity of her right eye was finger counting 3 meters, best corrected to 6/60, with minus 8.5 diopters spherical and minus 2.5 diopters cylindrical at 90 degree. Visual acuity of her left eye was finger counting at 2 meters, best corrected to less than 6 by 60 with minus 16.5 diopters spherical and minus 1.5 diopters cylindrical at 90 degrees. On slit lamp examination of anterior segment, it revealed microcornea with corneal opacity inferiorly in both the eyes. The patient also had horizontal nystagmus. On Goldman aplanation tonometry, the corrected IOP of the patient was 20 mm Hg of the right eye and 12 mm Hg of the left eye. On gonioscopic examination, both eye had grade 2 Sheffer's grading of the angle. This is the photo of the patient in primary gaze, and this is video showing horizontal nystagmus. Since the media was hazy due to corneal opacity and the patient couldn't fixate due to nystagmus, the fundus photo could not be obtained clearly, but the disc showed normal size and color. It was sharp with well-defined margins. Cup disc ratio was 0.4. Retinal vessels were normal. There was myopic crescent. Tessellations were present, and diffuse chorioretinal atrophic patches were present on the macula. The left eye also showed a similar picture, but there were more atrophic patches. The corneal diameter horizontal was 8.5 mm in both the eyes. It was measured using Castro-Viejo calipers. The horizontal radius of curvature of cornea of the right eye was 8.03 mm, corresponding to 42 diopters, and 8.15 mm in the left eye, corresponding to 41.5 diopters. The vertical radius of curvature of cornea of the right eye was 9.64 mm, corresponding to 35 diopters, and 8.65 mm, corresponding to 39 diopters in the left eye. The central corneal thickness of right eye was 576 micrometers and 638 micrometers in the left eye. Anterior chamber depth of the right eye was 2.60 mm and in the left eye was 2.55 mm. The axial length of right eye was 27.18 millimeters and in the left eye was 29.96 millimeters. This is the anterior segment OCT findings of the patient, showing the radius of curvature, horizontal and vertical, and the central corneal thickness. The OCT shows a little corneal stromal edema. A similar picture was present in the left eye as well. The B scan shows presence of posterior staphyloma in both the eyes. Coming to the differential diagnosis, there are a few genetic syndromes associated with microcornea and myopia. Microcornea could be associated with myopic chorioretinal atrophy and telecanthus in MMCAT syndrome. It could be associated with coloboma, macrophthalmia, and microcornea in MACOM syndrome, and microcornea, rod cone dystrophy, cataract, and posterior staphyloma in MRCS syndrome. We came to a provisional diagnosis of bilateral microcornea with pathological myopia associated with posterior staphyloma and nystagmus. Since the patient had nystagmus, there was loss of fixation and little to no improvement with glasses. Guarded visual prognosis was explained to her. She was counseled for subsequent low vision aids requirement. Microcornea is a horizontal corneal diameter less than 10 millimeters. It is related to fetal arrest of corneal growth in the 5th month of gestation due to overgrowth of anterior tips of optic cup. It is due to genetic mutations inherited either autosomal dominant or recessive. It is mostly associated with ocular or systemic syndromes, but most commonly it is associated with microphthalmos or hypermetropia. Association of microcornea with myopia is a rare ocular finding. It could be due to a genetic variation which would need further investigations. But it is prudent to be aware of this association. Axial length and posterior segment examination can routinely be done in patients presenting with microcornea. These are my references. Thank you.
Any questions from the audience? Did you try any genetic testing in this patient?
Sir, that time we didn't, but we are more aware of the associations right now.
Okay.
And in any subsequent patients, we will definitely.
Is there any family history in this patient?
The patient did not give any family history.
Is there any history of consanguinity among the parents?
No, sir.
Or grandparents?
No, sir.
No. Thank you. He'll be talking on atropine 0.01% effect on progression of myopia. Is Dr. Abhinav Agarwal here? No. Then we'll go to Dr. Dega Hanisha. She'll be talking on study on macular and RNFL parameters in unilateral amblyopia.
Good morning everyone, I am Hanisha. Today I am going to present on study on macular and RNFL parameters in unilateral amblyopia. There is no financial disclosure. Coming to the introduction, amblyopia is unilateral or bilateral reduction in visual acuity induced by aberrant visual experience early in childhood during visual system development. It occurs in 2 to 4% of general population. The risk factors include strabismus, anisometropia, visual impairment, and high refractive errors. Usually, previously it is assumed that it is caused by functional and morphological changes in the visual cortex and lateral geniculate body. But recently it has been seen that amblyopia affects the postnatal retinal development, which may alter foveal thickness and RNFL thickness in amblyopic eyes. Our aim was to compare and access the average RNFL and macular layer in unilateral amblyopia with fellow eyes and age-matched controls using OCT. Coming to the materials and methodology, it is a case-control study where the case group included 44 amblyopic patient eyes with their 44 non-amblyopic other eyes serving as internal controls, whereas 32 eyes of 32 age-matched subjects without amblyopia served as the external control. It was conducted in the tertiary hospital for a duration of 1 year. Complete ocular examination has been performed. The inclusion criteria included age more than 10 years, patients giving consent, unilateral strabismus or anisometropic amblyopia with no anatomical disorder, whereas the exclusion criteria included the history of glaucoma, any organic lesions or intraocular surgeries, bilateral amblyopia, deprivational amblyopia, any ocular pathology affecting the best collected visual acuity, and the patients or guardians who are not giving consent. Complete statistical analysis was performed. Coming to the results, this table shows the demographic profile of the study population. The number of the amblyopic eyes were 44, whereas the external control was 32. The mean age of amblyopic eyes was 20, and whereas the external control was 23. The male and female population in the amblyopic eyes was 20 and 22 respectively, and whereas in the external control group it is 14 and 18. Intraocular pressure was almost similar in both these groups. The best corrected visual acuity in the logMAR units in the amblyopic eyes was 0.51, whereas in the external control is 0. This table shows the distribution of the amblyopic patients. The anisometric amblyopia in our study was almost 90%, whereas the strabismic amblyopia, it was 9%. This graph shows the refraction distribution of the study group, where the myopic and hypermetropic patients were almost of equal percentage and the astigmatism were little less. This is the table showing the comparison of sound and amblyopic eyes in different types of anisometropic amblyopia. In this, the different types of refraction, a myopic, hyperopic, and astigmatism, the refractive errors range was compared within the amblyopic eye to the sound eye, which shows the statistically significant difference. This is the table showing the comparison of macular parameters between amblyopic and sound eyes. In this, the central macular thickness and the each quadrant of the inner circle and the outer circle was compared between the amblyopic eyes and the internal control group, where the amblyopic eyes showed slightly thicker compared to the internal control group, but it is not statistically significant. This table shows the comparison of macular parameters between amblyopic and non-amblyopic eyes, where the amblyopic eyes showed slightly thicker in the central macular thickness and inner and outer quadrant compared to the external control, but it is not statistically significant. This table shows the comparison of RNFL thickness parameters between the amblyopic and the internal control eyes, where the average RNFL thickness and each quadrant has been taken in consideration, where the thickness is increased in the amblyopic eyes, but it is not statistically significant. This table shows the comparison of RNFL thickness parameters between amblyopic and non-amblyopic eyes, where the amblyopic eyes showed increased thickness, but it is not statistically significant. It is the relationship between the RNFL thickness parameters and spherical equivalent of the amblyopic eyes showed significant in the average nasal and superior and inferior quadrants. Coming to the discussion, in the current study, amblyopic eyes had slightly thicker macular and RNFL thickness parameters than fellow and non-amblyopic eyes, although this difference was not statistically significant. In these tables, the few studies were mentioned that are conducted in India where they showed different results. Coming to the conclusion, we found no significant variations in RNFL thickness and macular parameters between unilateral amblyopia, mostly the cause being the functional. Thank you.
Just on time. Any questions? Yes. How do you define amblyopia, madam?
Sir, amblyopia is nothing but
Yes.
amblyopia is nothing but the decrease in the best corrected visual acuity less than 6/12, less than 6/12 with no ocular pathology.
Okay. So what are the types of amblyopia you have
Sir, I have
encountered?
mentioned about the anisometropic and strabismus amblyopia. Sir, we had anisometropic amblyopia, more number of cases we have got. Sir, strabismus we have got around only 4 to 5.
There are no other cases
No,
of
sir,
ametropic amblyopia
No,
or
sir, we haven't in our inclusion
stimulation
criteria,
deprivation
we have-
amblyopia.
No, sir, there were very little number of those cases, so we have taken that as exclusion criteria. Sir.
Yeah. Thank you.
Okay, sir,
Can I call Dr. Jil Kumar? Is he ready? Yes. The first one, sir. First one, sir. Yes, sir.
Actually, I'm sorry for the inconvenience caused by me. So, good afternoon. I am Dr. Jil Garala, Senior Resident in Ophthalmology in Siusha Medical College from Gujarat. I'll be presenting study of the digital eye strain due to extensive digital device use among the UG medical students in tertiary care teaching hospital. Technology has transformed every realm of our lives in the information age, from healthcare to education, prompt communication, extensive availability of the information, and going paperless or go green are the various advantages. However, every action comes with its opposite reaction, and the digital revolution is no exemption from this rule. Digital eye strain includes a group of ocular and vision related problems attributed to prolonged use of the desktop, laptops, mobile phones, tablets, and screen. Its pathophysiology is multifocal with several contributing factors being reduced contrast level of the lighters compared to background digital screens, glaring, reflections, wrong distance and angle of viewing the digital screens, poor lighting conditions, and infrequent blinking of the lights. The condition can cause various symptoms like eye strain, watering, headache, tired eyes, burning sensation, redness, irritation, dryness, foreign body sensation, blurring vision at the near, and diplopia. Online learning services served as a remedy during the pandemic. There was a rise in usage of internet services from 40 to almost 100% compared to the pre-lockdown levels. Being restricted indoors, digital devices became the only source of entertainment. Ultimately, this has resulted in an upsurge in the symptoms of digital eye strain among the most individuals, irrespective of age, sex, race, or region. There was a cross-sectional study was conducted among randomly selected 100 UG medical students of Siusha Medical College in Surendranagar using a pre-designed questionnaire into their digital device use pattern, symptoms of the digital eye strain experienced by them. Those who experienced one or more symptoms related to the digital device use were considered to have DS. Data collected was entered in the Excel sheet and analyzed. Descriptive statistics was expressed as frequency and percentage. Chi-square and Fisher's exact tests were applied accordingly. In results, the study indicated 80% prevalence of DS among the students, of which the prevalence among the female and male were 37% and 63% respectively. 84% students were using devices held less than 1.5 feet from the eyes. The digital device preference among the students was maximum 56% for smartphones, 24% for laptops or computer, and 20% for notepad or iPad. 71% students were using devices for more than 3 hours per day. This is the table which includes the various symptoms, in which 11% symptoms of moderate severity was watering, and highest was headache with 15% of moderate severity, whereas severe symptoms are less compared to the other symptoms. So factors associated with digital eye strain, like duration of use, preferred device, and distance from the eyes, in which 39% of students were using for 3 to 5 hours, 32% students for more than 5 hours, 23% students were using laptops, and 56% were smartphones. Majority of the students held the devices 1 to 1.5 feet, like 54%. This is the female and male distribution, in which 22% of the male use 3 to 5 hours, and total 33% use for 3 to 5 hours. And discussion in prevalence in present study, 80% students stated experiencing the symptoms of DES. The prevalence of DES is ranged from 53 to 73% in several other studies, which includes the mean age of 22.5 years and male predominance 63%. In symptoms in present study, 55% had burning sensation, 53% had itching, 60% had watering, 58% had headache, 49% had pain and heaviness. Several other studies also reported watering and headache as the most common or disturbing symptom following the usage of digital devices. While there are challenges in determining the prevalence of DES, levels of 50% or more have been reported in numerous published studies. Now, conclusion: usage of digital devices for work and social purposes, often for many hours each day, is now normal among individuals of all ages. Digital device use of more than 4 hours per day, underlying refractive errors, and prior dry eyes are the most significant risk factors. So, digital device use in myriad form, ranging from smartphones to laptops, lead to high prevalence, and due to inappropriate practices and like inappropriate distance from digital screen and inappropriate duration of use. Thank you.
Any questions from the audience? Okay. So did you do any type of cycloplegic refraction in your patients,
Yes, sir.
doctor?
In every patient.
In every patient?
Yes, sir.
So what were your findings?
Mostly were refraction was present, like they were already myopic, most of the patients, but there was some increased level of myopias after the duration of 1 year, at the end of 1 year, because they are still my students at there. So I am continuously calling them yearly and some 6 monthly. So there is significant increase in
Progression
numbers.
of
Yes, sir.
myopia
Definitely
was
progress.
observed.
Yes, sir.
Okay. So this digital eye strain, what could be the main leading cause for the digital eye strain? Is it dry eye, or is it strain of the eyes, or is it a change in the refraction, or there is any imbalance on the
Most
part of the
students are complaining of using devices for longer time for the day. That
Yes.
is the direct cause I have found in my
Yes.
studies.
Yes.
Other causes are risk factors rather than directly associated during this study.
So did you try to find out the reason by
Yes, sir.
assessing
I'm
any
still-
accommodation by AC by A ratio or any other parameter?
No, sir, but I'm still trying. I'm continuing my study to the next level. So,
Okay. So take up another study
Yes, sir.
with the
yes, sir,
similar topic.
definitely.
Yeah,
I'm
thank
still
you.
continuing this.
Yeah,
Yes.
thank you.
Thank you, sir.
Dr. Raj Vador? No. Uh, Dr. Patnaik Sabyasachi? Dr. Patnaik Sabyasachi? Dr. Midhun Tulsi Das? Already completed, sir. She was supposed to attend her to duties, sir. So she was allowed ahead in the first. Yes, the last one.
So respected chair and delegates, wish you all a very good afternoon. So I would like to thank AOI Scientific Committee for recognizing this paper and choosing it as the best paper at the last midterm conference. So I'm Dr. Mithun Tulsidas. I'll be talking about corneal tomography in fellow eyes of unilateral keratoconus for detection of subclinical keratoconus. I have no financial interest, so I would like to share my brief experience on how I thought of doing this study. So does unilateral keratoconus really exist? So that will be a question which most of us encounter. But when you do a literature search, you can say that true unilateral keratoconus is a very rare entity. So keratoconus is mostly a bilateral disease with an asymmetrical presentation. So when one eye manifests as keratoconus, the other eye must be the earliest form of keratoconus or maybe a subclinical keratoconus. So what if we can find some parameters which can distinguish these fellow eyes of unilateral keratoconus from the normal eyes? Then obviously those parameters might be the earliest indicators to detect an abnormal cornea or keratoconus. So that was the main thought process behind this study. So studies suggest that subclinical or clinical keratoconus is found in 1 to 6% of the myopic patients undergoing refractive surgery. This is mainly due to one reason, because the detection of the disease in the preclinical stage is difficult. So this is a good pictorial representation which actually defines some of the terminologies. As you can see, the yellow arrow, that is actually the topographic parameters. So there will be a cutoff beyond which, if certain criteria are met, we term it as keratoconus. And as you can say, keratoconus suspect needs some tomographic features to be fulfilled, whereas in a forme fruste keratoconus, it can manifest even without much of tomographic features. And both come under the category subclinical keratoconus. So a forme fruste can be a false negative which might be missed even with the current screening techniques, and sometimes we might overestimate a case as keratoconus too. So the purpose of the study was to analyze the tomographic changes in fellow eyes of unilateral keratoconus patients by comparing them with normal eyes. So this was a 5-year retrospective comparative study, and patients with unilateral keratoconus diagnosed by Pentacam and normal candidates of refractive surgery were included. So there were 3 groups, one group with advanced keratoconus eyes, and the another group with normal fellow eyes, and the third group with normal candidates. And you might be thinking about the smaller sample size, but in this study we have exclusively included only those eyes in whom the fellow eyes are absolutely normal. That is, even it is clinically normal and even with a D value less than 1.6. And the examination was performed using Pentacam and all the maps were compared. These were the statistical methods used. So 64 eyes were retrospectively analyzed, and the keratoconus manifested mainly in left eyes and in male patients. So these are the 5 parameters which actually showed a significant difference between the fellow eye and the normal group. Now we have plotted an ROC curve just to find which parameters can actually distinguish the fellow eyes from the normal eyes. So these were the 4 parameters with an area under curve more than 0.7. That is the D value, D thinnest point displacement, and pachymetric progression index maximum. You can see they have good sensitivity, however the specificity is little on the lower side, and this was the first data ever in the Indian population. D value and PIVAX were the most characteristic indices in our study in discriminating fellow eyes with normal eyes, similar to the few studies done by Vasquez et al. And Hussainli et al. However, ours is the first study to have such data in Indian population. We do have a limitations of a small sample size, but as we all know, the incidence of a true unilateral keratoconus is very rare. Thus, this is unlikely to skew the results of the study. However, further studies with a larger sample size and simultaneous evaluation of the recent corneal biomechanics and wavefront aberrations may be more useful. To conclude, bad D value and pachymetric progression index were more effective than other Pentacam parameters in detecting the earliest form of subclinical keratoconus. And yes, the present study supports the usefulness of Pentacam. However, a single parameter alone is not enough to detect early changes. We need a combination of data. Thank you for your kind attention.
Thank you. So Is Pentacam the best machine to assess
No, sir.
keratoconus?
Right now, we have the corneal biomechanics and wavefront abrasions also in the picture. So we
Yes.
can also use those machines, like even a Corvus ST, which is
Yes.
found to be, you can actually do a combination of things, not a single machine.
Yes. And what is the latest in assessment of keratoconus?
No, sir, this is the machine which we had in our setup, but yeah, we can always use a Pentacam HR with a bad map with the third bad map. Bad map 3 is the latest one, which actually includes an ART max, a K max, and elevation at the thinnest point. So if we have a latest machine with inclusion of bad 3, because this was
What
done.
is ART?
ART is Ambrosio relational thickness.
Okay.
So if this is basically including bad 2 maps, this study was done. So if we have a bad 3 map coming in the picture, then it would be given more clear picture.
Is epithelial mapping helpful in keratoconus assessment?
Definitely, sir, definitely. I have not done a study or I am not familiar with it, but
No,
definitely the
that's
studies say
that's
epithelial
the latest
mapping.
concept
Yes,
in
sir.
keratoconus
Yes, sir.
Assessment.
Yes.
Yeah.
Thank you.
Thank you.
Thank you, sir.
All the presentations covered. I conclude the session. Thank you for the attending and participating in the. Doctor, మీ నంబర్ వేసారా?